Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 494 of our pharmacotherapy series, which majors in acute kidney injury. The first case reads, AVB is a 86-year-old white man whose height is 5 feet, 2 inches and weight is 138 pounds, who was admitted for elective aortic valve replacement secondary to severe aortic stenosis. He became hypotensive during surgery, requiring aggressive fluid resuscitation. He is now in the ICU and requires vasopressors for hemodynamic support. His BUN is 88 mg per deciliter and his serum creatinine is 3.5 mg per deciliter today. His renal function tests have remained at these levels for the past 3 days. His baseline serum creatinine before surgery was 1.2 mg per deciliter. Despite IV fluids, AVB is oliguric with a urine output of 15 ml per hour, translating to 350 ml per day. So my first question to you reads, do diuretics and dopamine have a role in treating acute tubular necrosis, abbreviated as ATN? It is well documented that patients with non-oliguric renal failure have significantly better outcomes compared with those with oliguria. This is probably because patients who are non-oliguric have less extensive renal damage and are better able to maintain fluid and electrolyte balance. Loop diuretics have been used in established acute tubular necrosis in an attempt to convert patients with oliguria to a non-oliguric state despite the lack of conclusive evidence for their benefits. Numerous clinical trials, however, have failed to demonstrate improved mortality or duration of azotemia in oliguric patients who receive loop diuretics, despite improved urine output. 2 large systematic reviews of the primary literature convincingly showed that diuretic therapy plays little role in altering the course of acute kidney injury, decreasing length of hospitalization, or helping recover renal function. These data suggest that although patients who are non-oliguric generally have better outcomes, converting a patient from oliguria to non-oliguria through pharmacologic intervention does not improve patient outcomes. Currently, the only role that diuretic administration has in patients with established acute tubular necrosis is to increase urine output, which facilitates fluid, electrolyte, and nutritional support. Another controversy that has been debated extensively in the literature is the use of dopamine in patients with established acute tubular necrosis. Dopamine is a catecholamine that stimulates dopaminergic receptors at low dosages, that is 1 to 3 micrograms per kilogram per minute, and alpha and beta receptors at higher dosages, that is 5 to 20 micrograms per kilogram per minute. Animal and human studies have demonstrated that low-dose dopamine improves renal blood flow by inducing afferent arteriolar vasodilation. No data, however, support the use of dopamine in the treatment of established acute kidney injury. A meta-analysis of 61 clinical trials, including nearly 3,500 patients, failed to detect any significant improvement in variables such as occurrence of acute kidney injury, need for renal replacement therapy, or mortality. Unequivocally, dopamine has no role in preventing or treating acute kidney injury. Other modalities such as phenyldopa or atrial natriuretic peptide, abbreviated as ANP, have not been shown to be conclusively beneficial to treat acute kidney injury and hence are not recommended to be used. Renal replacement therapy would be the most appropriate to use if life-threatening changes in fluid, electrolytes, or acid-base balance are noted. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 495.